Good morning, everyone. Thank you all for being here, and I'd like to start us off today by acknowledging that here in Hamilton, we're located on the traditional territories of the Anishinaabe and Haudenosaunee peoples, and I am reflecting this week as I hear in the news about how this was the warmest February ever, and on the importance of our changing climate and how the Indigenous people have protected our lands for so long, and thinking about what we can learn from them as we move forward and navigate this tricky area. And that brings us into our topic for today. I'm delighted to introduce Dr. Sujane Kandasamy. She is an intersectional environmentalist, a knowledge translation practitioner, and a community-engaged mixed methods researcher trained as a health research methodologist. She has been working alongside interdisciplinary teams to strengthen opportunities for improved health and wellness in Indigenous and newcomer communities for many years. And she is dedicated to using community-driven and culturally authentic research designs and interventions that use strength-based approaches. Sujane is currently a postdoctoral fellow at McMaster University and Brock University, working to co-design sustainability-focused healthy active living interventions in partnership with newcomer and refugee communities. She is also the co-lead of the Partnerships for Environmental Action by Clinicians and Communities for Healthcare Facilities, or PEACH Health Ontario, and co-founder and director of Learning and Development at the Starfish Environmental Society of Canada, a planetary health-focused charity. She will be presenting today alongside Dr. Myles Sargent, who is a family physician who has worked with vulnerable populations, including people experiencing homelessness and/or addictions, and the elderly for the past 25 years. Dr. Sargent recognizes the intersection between environmental issues and health, and he is dedicated to addressing climate change issues and has co-founded Partnerships for Environmental Action by Clinicians and Communities for Healthcare Facilities, the charity Trees for Hamilton in 2012 in Hamilton, and the not-for-profit Shelter Health Network in 2005. Dr. Sargent is now the Executive Director of the Canadian Coalition for Green Healthcare. And I'm delighted to turn it over to the two of them. Thank you.
Thank you, Dr. Anderson. It's a pleasure to be here this morning, along with my colleague, Dr. Sargent. So we will present today on opportunities and challenges in planetary health, a look into how partnerships can mobilize sustainable practices in health systems. We'd like to acknowledge that McMaster University is on the traditional territories of the Mississauga and Haudenosaunee nations within the lands protected by the Dish with One Spoon Wampum Agreement. To me, that means to walk gently, but to advocate loudly. Don't be the first to take or the last to take, and only take what you need. Today in our presentation, Dr. Sargent and I will cover what is planetary health, how can we measure global warming, what is the impact on the healthcare system, of the healthcare system and on the healthcare system, what types of climate action are there and what opportunities we have to work together on this challenge, and what is one way that we can mobilize clinicians in climate action and measure the impact of that. So I'll pass it over to Dr. Sargent to get us started.
That's all you're going to do?
Well, I did have a joke, but I don't know if you want to hear it. Do you want to hear it? Okay. So we actually drove in together, and then Myles told me, Sujane, remind me to bring the saw with me. And then I thought, forgetting that I was with the president of Trees for Hamilton, wondered, is that what the murderer says to the murderee? But he really was bringing the saw to prune some trees locally, so Myles.
You're watching the wrong Netflix shows. So this is my disclosure. In summary, you don't make a lot of money in this sector. I think that's basically the summary. I am grateful that the PGME committee at McMaster does pay me 0.1 full-time equivalent to teach residents. I also earn 0.1 FTE from the Family Health Team Green Initiative, and most of my other work is voluntary, but I'm very happy to do it. It's obviously an important topic, and I have been paid by a few universities to do a talk similar to this one. This is a tough topic to present. I mean, people, and you can reflect on this for a second. What do you think of when you hear the phrase planetary health? I do a med student lecture every year, and they want me to present planetary health, and I only have about 50 minutes, and I actually go through about 120 slides in 50 minutes. I do my best, but it's a tough one to cover. And it's also interesting because some of you out there might know a lot about climate change and climate science, and others know nothing, so it's always tough to find that right balance of how deep I go here. So planetary health is essentially the intersection between medicine and environmental science. There's a simple definition of medicine at the top, and environmental sciences include a lot of ologies. There are many ologies in science, and so you look at the intersection there. I like definition B here. This is done by the Lancet. The Lancet has been interested in this topic. They were ahead of their time. They've been doing this for at least 10 years now. And then there's my simple definition at the bottom, how we impact the environment and how the environment impacts us. Planetary health, if you were to Google top 10 environmental problems, this is one website. They all have a similar list. There are many different environmental problems. Why do we focus on global warming? Number one, because you could argue it's the most urgent problem. It's the one that we need to decrease CO2 by 50% in the next 6 years. So that is why I'm motivated by carbon mitigation. And the other is because all those words in red are the places where global warming intersects with all these other planetary health problems. So this is why we focus on carbon mitigation, or decreasing the amount of CO2 that we make. What's the basic unit of measurement for global warming? It is the global warming potential. I'll read through this. So all greenhouse gases are not equal. Each one has a unique atmospheric lifetime and heat trapping potential. The GWP examines each greenhouse gas's ability to trap heat in the atmosphere compared to a carbon dioxide molecule. So one GWP, as you can see in green there, is 1 if it's CO2. That's the base unit. And methane is 83 times greater than CO2, one molecule. And nitrous oxide, which is laughing gas in medicine, 273 times greater than CO2. And desflurane is an anesthetic gas which we're trying to ban in Canada, 2,540 times greater than CO2. And so we can also translate this into CO2 equivalents. So we express everything in terms of CO2 equivalents to make things simple. And you're going to see that moving forward here. Now, this shows the increase in greenhouse gas from 1980 to about 2015, and how that line has gone up over time. And what I want to show here is that even though carbon dioxide as a global warming potential is smaller than the others, methane, nitrous oxide, there's so much CO2, it becomes the biggest piece here in green as it goes up. And you can see that over time, methane has stayed relatively the same, the red bar there. Carbon dioxide continues to go up, and I've put on the bottom there carbon dioxide burning of fossil fuels, oil, gas, coal, methane, waste from landfills. Obviously, cows belch out methane, and nitrous oxide, as I mentioned already. So now that you know a little bit about CO2 equivalents, what's the global warming potential of one mask? Well, it's only, what would that be? 0.02 kilograms of CO2, so not a big deal. But here's the problem in healthcare. This is an artist from the Netherlands who asked her surgeon if she could keep all the waste from her breast reconstruction surgery. And there she is with all the waste from one operation. So this is why we have a problem within healthcare. And again, just to show you what these numbers mean, your pet dog, we have a pet dog, is about 750 kilograms of CO2 per year. The average Canadian is about 10 tons of CO2 per year. A car driving in Canada is about 6 tons. A delivery truck, over 100 tons. Walmart, to run a typical store, we're getting into 1,000 tons. CHEO is our children's hospital in Ottawa, and they are around 17,000 tons per year in their CO2 emissions. Okay, so more than a rocket taking off. So there's a lot we need to do here. And thanks to Dr. Richard Webster, he's the big data person for CHEO, for giving the slide to me. Okay, so now you may not be surprised that the CO2 emissions from healthcare are 5% of our national emissions, and that's everything. That's all the cars we drive, that's all the houses we live in, that's all the manufacturing that we do. Healthcare, 5%. This is a typical number for a wealthy nation. So the global north, whether it's North America, Asia, Europe, global north, has a big carbon footprint within healthcare. You can see I put the States there and Australia for comparisons. We learn in medicine, above all, do no harm, but unfortunately in our course of business, we do a lot of harm to the environment. And as a comparison, the airline industry is about 3.5% of our emissions. So healthcare is more than the airline industry. I slipped that first little graph down in the left there. That's where it belongs on this trajectory. Again, that was 1980, I think, to 2015. Just showing that this graph that I'm about to show, futuristic graphing of what will happen if we don't change. This is all in CO2 equivalents, but I'm just reminding you in the bottom left there that CO2 equivalents include all those gases. So I'll take that out. So from 1990 to 2020, 30-year period, you can see the black line in the bottom left and how CO2 has risen globally in gigatons. And this is where we go, potentially the pink at the top if we do nothing. What we want to do is follow the greenish blue line at the bottom. That's the 1.5 degree pathway you hear about to keep our temperature less than 1.5. I've added the bold red line to say we need to drop by 50% in the next 6 years. Believe it or not, I think this is possible. And I'll get into a little bit of the reasons why here. In Canada, we just showed you the global gigatons. Some people will say to me, well, look, what does it matter, Canada? We're a small country. It matters because we have an oversized footprint. This slide's a little bit old. The numbers have changed a bit, but in this one, I think this was 2017, looking at CO2 emissions per capita, we were number 3 in the world. Some people think it's because we're a cold country. Take a look at Sweden, 1/3 the amount of CO2 that we produce. I would say in summary, it's in part because we buy a lot of stuff. So healthcare creates greenhouse gases, and then in turn, greenhouse gases impact our health. These are all photographs from Canada in the last 5 years. Solutions. So almost 3 years ago, Sujane and I and a couple other people co-founded Peach Health Ontario, partnerships for environmental action by clinicians for health facilities. So it's an acronym. And we planned to reach out, this is an Ontario initiative, to facilities in Ontario that were doing amazing things around climate change, because there's lots of great examples, and scale up the work that they do. We started by visualizing what the ideal green facility might look like. And as you can imagine, if you take the H off the front of that hospital, it could be a McMaster building, it could be a library, it could be the David Braley Family Medicine Center just across the street. So these concepts apply to all different sectors, especially if you take out drugs and devices. We feel that if you can go after these 8 categories, you can approach the ideal green facility. And these are somewhat arbitrarily chosen, but these are the 8 categories we go after, and we do projects, and we have developed partnerships, and we do research. So I'll be getting there in a second. This was done by Tennyson in 2021. Big article, highly referenced article in the UK, looking at the carbon footprint of the national health system in England. And there were years and years of research that went into this. So this is a summary of ambulances, dental offices, primary care, hospitals, long-term care, you name it. What does the footprint of the healthcare sector look like? This would be very similar to what Canada looks like. They also have a public system. And a couple things I always like to point out. We always think about building energy when we think about CO2. You can see there in red, by the way, the red section is essentially what happens inside the building. I mean, they also include fleet transportation there, but essentially that is what is happening inside the facility. The green pieces you can see is transportation, visitor travel, staff, and patient. And then the alarming piece, at least to me, is the fact that supply chain in their study was 62%. And I'll get to that. Building energy, only 10%. That is in part because over the last 30, 40 years, there's been a lot of work done by engineers to, LED lights, better boilers, et cetera, et cetera. So that piece of the pie has been squeezed down. Personal travel, not as big as you might expect. Supply chain, massive, and in particular, the production of medications, 22%. And then that doesn't even include the emissions from the gases themselves, which you see at 10 o'clock over there, anesthetic gases and meter dose inhalers is another 6% or so. So pharmaceuticals are massive within our industry. So we again make projects for each of these things. Leadership, you need to have a strategy and you need to have a person most responsible at your hospital. These are the original 3 hospitals I would talk about a couple years ago. I could add several more. You'll be glad to know many hospitals now have a strategy, including Hamilton Health Sciences. A year and a half ago, added sustainability as one of their 4 pillars of excellence, which is great. So one of our first projects was to make a guidebook for healthcare leadership. And we thought through essentially like a Pareto analysis, 20-80 rule. There are many, many things you could do at a hospital. If a hospital is going to take the time and energy to set up a leadership structure and go after this big problem, what are the big things to go after? So we made a guidebook. It's short. It's about 10 pages. This is the centerpiece. These are the action items. These are the items we feel are the most important items to go after. And so when I do speak to hospitals about this problem, I tell them, look, recycling is important. It doesn't make the top 20. These are the items potentially in the top 20. We could debate this. This is now 2 years old. We missed 1 or 2. We need to add them. But the other point is that leadership needs to have all these different people at the table. You need your educators at the table. You need your procurement lead who buys things for the hospital, pharmacy lead, food manager, et cetera. It's not all about the building engineer. Sujane is going to talk a little bit more about that later. Supply chain, teaching point here. Supply chain, we think about not the 3 R's, but the 4 R's. We need to refuse, R number 1, we need to refuse the bad products. So we have lived in a linear economy most of our lives where you dig something out of the ground, you ship it to manufacturing, you ship it to packaging. In our case, you ship it to the hospital. If it's a throwaway gown, I might only wear it for 1 minute, depending on what I'm doing. Then I throw it out, and then it gets shipped to garbage or incineration. So that is a linear economy. We have 8 billion people in the world. We buy a lot of stuff, both personally and within healthcare. So we need to move to the circular economy. Circular economy just means that, like this shirt, it's 20 years old. I probably shouldn't be mentioning that, but it's true. Does it look 20 years old? Thank you, Russ. We need to reuse things. We need to support circular economy. We need to take our shoes in to be re-healed. We need to support that type of the economy. In healthcare, we need to use reusable gowns which we do use in HHI, Hamilton Health Sciences, can be used and washed 80 times. And engineers at McMaster are working on making those gowns last 200 times. Procurement scoring, so what do we actually do about this? I do crazy things like I cold call procurement leads of the big hospitals in Ontario, and I tell them, do you realize you are the biggest piece of the puzzle here for solving the climate crisis? And this is at the end of COVID. Most of them did not know that. We now have a group that meets every 2 months, and we talk about how we can move the needle here. And this is why I do feel good about the future, because Hamilton Health Sciences, for example, last May wrote a letter to 1,200 suppliers telling them they want green products, they expect green products, and it's going to become part of their scoring, not just cost, not just quality, but also how do you score on sustainability. And other hospitals are doing this, and other sectors are doing this. This is a graph which was made by, oh gosh, I don't have the full name there. It's a university, oh, there it is, good, Copenhagen Business School. This was done thinking about supply chain disruptions. But I love this graph because it shows what we do when we make products. There are 2 pathways shown here to make a computer. One starts in Chile, number 1, bottom left. You dig the things you need out of the ground, raw materials. You ship them to Southeast Asia, number 2. Then you ship them further north in Asia, number 3. Then you ship them into China for final assembly, number 4. Then across to Mexico, number 5, for packaging. Then finally up into Canada to the consumer. And then, of course, we use it and throw it out. And I understand some people only use their computers for a few years. I use them for 10. That probably doesn't surprise you. But I saw this and I thought, gosh, what is the journey of a pill? Well, try looking that up. So life cycle analysis, that partly shows the global warming potential, but it also should show water use, forest use, etc. So you can look that up. Tell me if you find something. I couldn't find anything. The pharmaceutical industry, we need to partner with the pharmaceutical industry. I don't want to point them at the villain, but it's kind of like Willy Wonka's chocolate factory. You do not get in there. We do not know what happens. We do not know the carbon footprint of medications. So drugs and devices, metered dose inhalers, the blue Ventolin puffer is a 180-kilometer car ride for a full inhaler. There are better inhalers. And we do need to think as physicians, am I prescribing the right thing? Does this person actually have reflux? And I'm giving them a puffer for reflux. It's not actually asthma. Anesthetic gases, I mentioned desflurane, 2,500 times worse than CO2. I had to change the slide this morning. A year ago, that said 6 hospitals. Now it's 20 hospitals in Ontario. We expect this in the next couple of years to be completely banned in Canada, optimistic. And prescribing less meds. I work at a hospital that my patients come to me day 0 on admission on 19.1 meds each. I see frail elderly patients, 19.1 meds each, 13 regular meds, 6 as needed meds. It's too many. We can prescribe less meds. So that's the responsibility of physicians. So finally getting to some articles here. We wrote this article last year. We chose iron deficiency because iron deficiency impacts roughly 2 billion people in the world. It doesn't mean all 2 billion are on iron tablets, but a lot of people are on iron tablets worldwide. Do they need to be? There were some recent studies which showed that traditionally we prescribe iron tablets twice a day or 3 times a day for people. And iron tablets are probably more effective taken once a day or every other day. So with the green lens that we have, the important point here is that that's less medications that we need to produce. This just went into a journal 2 days ago. It will be in preprint in about a week, so I apologize. I have it blurred right now until it's in preprint, but this is the journey of the pill. We spent 2 years on this. We had 3 master's students in engineering at McMaster do the research. I reached out to, I cannot tell you how many people in the pharmaceutical industry, who said they didn't know what the journey of the pill was. So we did our best from all the research we could find. You can kind of see from some of the colors there that it's a big journey. We looked at a benzodiazepine, which is a sleeping pill. We picked that one because it's overprescribed. It has addictive properties. It causes all sorts of harms for elderly people like falls, etc. And hopefully you'll be able to see that soon, the journey of a pill. Now, I would love to have looked at the full life cycle analysis, the global warming potential, but then you really need to get inside of those buildings at every step of the process and see what the carbon footprint is. This is simply the journey, and it's a long journey. Transportation, that's obviously affects every sector, affects our sector. It used to be that a bike-friendly facility was the best thing we could do, and it still is a great thing to do. It's typically the doctors and nurses that are biking in. Clearly, patients don't typically bike to the office. So virtual medicine has become an even better option. We learned about that during COVID. We need to keep that option. Here's a study done in England a couple of years ago at a pharmaceutical conference where North Americans were flying across the Atlantic to the conference. The people who traveled are on the left, the pink slide. So again, you guys understand kilograms of CO2 now. The big pink dot is the airplane. The people on the right stayed at home and did a virtual conference, and they added up to 10 kilograms of CO2 for the weekend, internet and office, versus almost 1,900 kilograms to fly to the conference. The point is, I always argue for the virtual option. And this is clearly why. Not to say we can't fly anymore or we can't get together, but we need to have the virtual option. Buildings and energy, not going to spend a lot of time on that, but again, this ends up only being 10%, as I showed you in the beginning. This is still important, but only 10%. Food is a massive one worldwide. Plant-rich menus and decreasing food waste are two of the biggest things we can do globally. I'm not talking about healthcare, that we can do globally to decrease our footprint in the next 25 years. And this is why this looks at greenhouse gas warming potential of the different foods we eat. That is lamb on the far left, then there's a cow, and then we move across through dairy products and fish. And the moral of the story is eat potatoes and tomatoes. That's the moral of the story today. But we can measure this, again, kilograms of CO2. And so you could measure a menu of a hospital. And this is why we need to make a plant-rich switch. So with all that information, you can see how we use the information from different sectors to create the low-hanging peach tree. And you can see on the bottom right, some of this is obviously Sujane had big impact here. I wanted to call the greenhouse gas savings bottom right big, medium, small. Isn't that what you'd call it? No, it's game changers, difference makers, and needle nudgers, okay? You want to pick the orange fruits. We did this to compare apples and oranges. We wanted to show hospital leadership. So this is a hospital. This is theoretically a 200-bed hospital over a 1-year period. And how much greenhouse gas you can pull out of that hospital by picking these fruits. On the left, there's a logarithmic scale, which shows the cost. So you can see cost neutral at 0 and go across the tree. Plant-rich menus are at roughly 2 to 3 o'clock there. So again, we just looked at foods. If you can switch from the usual diet at a hospital and switch over by 20-25% toward more plant-rich options, I'm not talking about making a vegetarian diet, I'm talking about making a switch to plant-rich, that ends up becoming one of our big items of over 100 tons of CO2 saved per year. That one needs to be changed. We looked at a study in California which suggested it was slightly more expensive to have plant-rich. There's a huge study done in New York City. It saves you 60 cents per meal. I need to move that one down to cost saving. But the bottom line is you can see a lot of these items are cost saving items. How's our time? I get carried away here. Anyway, okay, I'll keep going. Yeah, so we need to pick the orange fruits, and interesting to see EV chargers. We like to joke the CEOs drive Teslas, so they always want to put in EV chargers at the hospitals. EV chargers up there at 10 o'clock. We just put in exactly 4 EV chargers at our hospital. I think it costs around $20,000 to $30,000. It's a great thing, but it's a needle nudger. Again, if we're getting to net zero, we need to pick all these fruits, but because it's a climate emergency, I urge the hospitals to go after the big things first. So we have this study in preprint right now, and the senior author sitting right there in the second row, Russ D'Souza. The idea being, we did a lit review, and surprisingly, there is data out there to say what is the carbon footprint of one bed per day in a hospital. That's far left. Study done in the States, studies done in Australia, studies done in England. No one had looked at comparing hospitals to long-term care or hospitals to home care. And so we used BC data on the left, those first 4, and then we used some data from Laval. They'd done a very thorough study to look at scope 1 and 2. Scope 1 and 2 is everything but supply chain, so it doesn't cover the whole thing. But bottom line is, in BC, 11 hospitals averaged out to 30 kilograms of CO2 per bed per day. We have hospitals which are, well, really, really overcrowded, and we have a big problem in our healthcare system. More importantly, we have patients who do not want to die in hospital. In Canada, 85% of Canadians will say they'd rather die at home, but most Canadians die in hospital. So what we're trying to show here is basically the green lens. We need to get patients home. We need to get patients out of our hospital system. And as you can see, from hospitals being 30 to long-term care being just under 9 to home care being under 1.5, there is a major green lens here to any initiative which helps to get people to long-term care or to home. And this is part of a toolkit we've made for primary care, because this partly is up to family doctors to do advanced care planning with their patients and make it clear to what does the patient want. Usually they don't want to die in hospital. The power of attorney needs to know. So this is something that we did in one of our toolkits, and I'm passing it over to Sujane now to talk more about our toolkits.
So I hope to iterate some of the points that Dr. Sargent has made, as well as share a little bit of an in-depth dive to some of our guidebooks. So hopefully you can see that planetary health is about action, and it's about multi-sectoral partnerships. It's about a team effort, and it includes a lot of different people at the table who bring a unique perspective towards the solution. So that's the approach that we take with Peach Health Ontario, as well as the guidebooks that we've produced. So just to give you a preview of some of the work that we've done, we've produced, in collaboration with various partners, guidebooks for different audiences. So the very first guidebook that we made was for boards, executive leaders, and clinical staff. So that was meeting hospital standards, but going beyond in terms of bringing the green lens into some of the decision-making across the 8 themes that Dr. Sargent mentioned. We worked off of that one, and then we also produced a more tailored version for long-term care. So you can see that it gets very specific for the community that's involved. And then also for clinicians and office managers. So if you're working in an office setting, there's obviously different considerations to be made, different opportunities to make change. But all in all, we hope that these books can engage, educate, but ultimately ignite change. From the work of this, we've tried to incorporate these 3 big pieces within all of these implementation guides. It includes a roadmap for sustainability. So we know that it a walk of 1,000 steps starts with the first step, as we might have heard. And many people might feel a little bit uncomfortable to take that first step. And a lot of people have been in that situation. So we've created this sort of roadmap to illustrate what the key steps are if you're fairly new to this, but also if you're seasoned in this space, there's still opportunities to build off and take the next step from where you are. The second piece is evidence-informed action items, simple and advanced recommendations. And then the third piece, which is very important, is around recommendations for sustaining the change within your office or facility, department, what the context is. Just to give, Myles showed a little bit of this, but essentially we take the 8 themes and then offer points within those themes. So for example, leadership, food, drugs and devices. It's a very simplified approach to kind of big picture actions that can be taken within those themes. We've since moved on to make specific implementation guidebooks for clinical communities. So you can see psychiatry, rheumatology, emergency medicine, internal medicine, and radiology. So our approach around this is to partner with representatives from those communities, multi-sectoral partnership to develop the books and also evaluate them. So this looks very complicated, but essentially, we're doing this work to engage with different partners to ignite change, but we also want to, at the same time, have an understanding of whether this is working, whether there's uptake, what the barriers might be to implementing some of these changes. So we are using the KTA framework, you can see, to evaluate both the process and the outcomes. So it includes a mixed methods approach to evaluate the adoption of the implementation tips, assessing the barriers, the facilitators to change, as well as to capture the change stories that are happening and to sustain the knowledge use. So I know we're out of time and we want to leave some time for questions. So we'd love to hear from you about what you think of all of this, or if you have any specific questions about anything we've discussed. Happy to answer, and Dr. Anderson will moderate. Thank you.
A terrific talk today, thank you. I'm sure there will be lots of questions in the audience. Where should we start? Start with Mitch.
Okay. So, working in a department that's obsessed with measurement, how confident are you about the accuracy and the precision of those numbers that you're generating about, what's the carbon cost or the greenhouse gas cost of individual activities and programs?
Thank you. I was asked to repeat the question so that they are in the microphone. So the question is related to measurement and the accuracy and confidence related to how well we are able to measure these estimates.
Pretty confident. It's interesting. As much as it's been a problem for society, some people were talking about this 40, 50 years ago, it still feels like a very, very new field. I was just talking to a colleague of Sujane's yesterday at U of T who's doing research on food. So I showed you that food slide. I think they're drilling down even deeper into the carbon equivalents. There's also difficulty translating from country to country because we are on different energy grids. So when you do look at the data, the bar graph I showed you of hospital, long-term care, et cetera, if you compare our hospitals in Canada to those in the US, to those in Australia, the numbers look all over the map. If you drive a Prius in Ontario or a hybrid car, and better example would be an electric car. Sorry, Prius is hybrid. If you drive an electric car in Ontario, you're on a grid that's 94% clean, although I think our premier is looking to make it lower, unfortunately. But nonetheless, at the time, it's 94. Quebec's grid is 99. and Alberta's is much, much less. So depending on where you're driving your electric car, it's cleaner in some provinces than others. So there's all these factors that do make it difficult to translate some of the stuff. And so that's why in our knowledge translation tree, we went with the orange, yellow, green. The items that ended up in the orange category were well over 100 tons, so we feel confident about that, about where they kind of, but the exact numbers, hard to say. Science is still evolving. So pretty confident, yeah.
Thank you. Jen.
Hi, thanks so much. This was really impactful, I think. And I'm just wondering about, so a lot of the tools and things have been for the healthcare system. And have you thought about, or do you have any advice for us who are sort of doing more, I guess, like, how do we estimate the impact of a research program or a research institute, like the actual research and our activities? The one thing that triggered that for me was the conference we were talking about. We're always flying around, doing these activities. So do you have a way of us thinking about that? Or have you thought about tools for researchers?
Thanks. So the question from Dr. Walker is about the impact of research in addition to healthcare facilities.
That's a great question, and I think we do think about that. And from our perspective, it's early on, but we're hoping to develop some partnerships there to sort of introduce a green lens to the way that we approach research. So, for example, we always think about the methodology, we think about the knowledge translation plan, but do we think about the environmental impact and not literal impact of research that involves, archaeology or like digging, but literally across the research process, where are the opportunities that we can act on really to reduce that impact. And so that is a work in progress. There has been some groups that have come together across Canada to look at the curriculum, the content, the research process, and have proposed a small framework around that. But lots of opportunities there. So if you would like to be involved in that, please, we would love to collaborate and generate a toolkit or a guide that would be helpful for researchers to consider as they're planning their research.
Are there other questions? Yes.
Wondering if there's any research on cost effectiveness about focusing on healthy active living, especially on diet, and how that training to people and overall people in the world would impact greenhouse gas.
So I think the question is related to what is the impact of training people in healthy, active living and diet on how that would impact on greenhouse gases.
Personally, in terms of this Peach project, we started by focusing on hospitals because that was the door that was open. We actually were going to start with long-term care, and we almost did, and I lucked upon a board member in Ontario who I knew, and so, you look at all these, I know that person, and they were super excited that we would do this for long-term care, and then wave 4 of COVID hit, and I haven't heard from them since. So we did focus on hospitals in part because the door was opening, and also in part because it's the most GHG intensive. Now we are starting to switch over to primary care, and there's been work done in primary care. So I'm getting to your question. So within primary care, family physicians have an opportunity to not only think about the prescriptions we write and whether we're overprescribing, because there's evidence that we overprescribe by as much as 10 to 20%, and choosing wisely in the tests that we order. Every single test we order has a carbon footprint. But from a primary care perspective, we are also in a position to give advice. In Canada's food guide is very plant-rich. We should be telling our patients to follow Canada's food guide, and that would actually be making a healthy switch. We should also be telling our patients, and we do, to get exercise and to try what we call active transport. So instead of driving to work, bike to work. So there's a whole bunch of things there, even smoking cigarettes. The cigarette industry, you wouldn't be surprised to know, has a heavy, heavy footprint. So it's not just for your own health, it's also for planetary health. So yes, there are things, and there is literature out there, but I'm just starting to dive into that to see what the most impactful items are.
I think we have time for one or two more questions. Yes.
Yes, I have a question for your presentation. First question is just is based on your toolkit. Do you plan about any accountability annually or something, that whether these hospitals are following these toolkits and how much they are up to their mark?
Great. So the question is, in response to the toolkit that you've developed, do you have a way of tracking and checking to see if hospitals are meeting their mark? Shaming the hospitals.
Yeah, no, we're both shy. This has been an area that we have not done as well as we should. And all our enthusiasm to get this out there, I can tell you, personally, I do a talk every week. We have this on our website. We send it out via social media. We have not tracked this as well as we should have, and we are just in the process of starting to do that. And this is where I hand it over to Sujane.
Thanks, Myles. So, Menaz, the last slide that we shared was really our evaluation framework. We know that it's important to, one, understand if people are even accessing the toolkits, how they're accessing them, if they're being used, read, if there's any change that is coming as a result of the recommendations. And so we're just putting in an ethics application to be able to evaluate that more in a structured way. And so maybe next year we'll have some robust answers on that, but it is in the works, and we are thinking about that, because ultimately that is the goal of all of this work, is to see that change and to see that change sustained. It's also an evolving industry as well, and so we account for that too. Like, the documents are as living as they can be, and we do go back and make iterations as new knowledge comes into play. So balancing both of those.
Thank you so much. So maybe I will end it with the final question, if that's, is there someone else who has a burning question? Cynthia, I'll let you take it.
Thanks for the presentation. It's thought-provoking. And so I'm wondering if you're foreseeing greater digitization of servers in hospitals, and they generate a lot of heat and a lot of electricity. Do you foresee that you might come up with one of these documents to guide hospitals use that with the heat energy, or consider that as part of the program?
So the question from Dr. Locker is about the digital impacts, I guess the impacts of e-health from hospitals on the impact on climate change.
It's a good point, and it's part of the reason why paperless office or paperless hospital did not make it onto the tree, because there's a massive trade-off there as we're learning, and I'm just reading about AI stuff like ChatGPT and how much energy that uses. I know there's an engineer at McMaster that's looking at having these, really hot systems that we use to make it part of the heating of the building. So I haven't looked at that, specifically yet, because there's a trade-off between paperless and electronic, but yeah, clearly it is something we should look at. I'm finding these questions are getting harder as we go. Is it break time, or what's it?
Then I'll finish it on an easy one, an optimistic one. I wanted to know, with all the students in the room, what do you think the greatest gaps in research are in this area? Where would you suggest for a new student, maybe Sujane, maybe this is a question for you. So for someone new who's interested in this area, do you have any suggestions of what research needs are out there?
Oh, there's lots of research opportunities. I think across the 8 themes, I think food systems and food inequality and all the intersects that come into play when you're talking about the food system, I think there's lots of opportunities there. It's a growing concern for the whole planet, really. And so I think there's some opportunities. I think there's opportunities with the life cycle analysis pieces as well. We know of one student who's doing a really great emerging project that brings together the life cycle analysis and the food systems work to do these raw calculations on the impact of typical things in our grocery store shelves. So we might not think, like an orange on our shelf, like what we often think about the nutritional impacts, perhaps the cultural impacts, the economic impacts, but also the environmental impact, and creating an index within that to kind of decide what are the top sort of foods that maybe we can focus on in terms of health, economy, and planet. So I think opportunities exist where the intersect lies. And that's the beauty of planetary health. It's an intersectional space. It's not just an environmental issue. It's a everything issue. It's a society issue. So even if you're interested in sociology, engineering, anthropology, there's lots of opportunities across that spectrum to be involved with the planetary health kind of outcome.
I'll just finish by saying my interest, and there's still a ton to be done here, and it goes back to Dr. Levine's question. What are the most impactful things that we should be doing? And so, from the healthcare perspective, if a new CEO is to join a hospital somewhere in Canada and decide this is a big priority for us, we've done nothing on this, I want to be able to say, these are the top 5 things you can do, and you can do them within the next year, and you can drop your carbon footprint by this much by doing them, as opposed to having them kind of wander along on a path which is not, if you have the energy and the motivation to do it, we want to be able to tell people what the big items are and how to get them done.
Thank you so much.